Thank you, Nesma. Hello, everyone. It's always a pleasure to talk to you. First of all, I would like to thank the Moroccan Society of Cardiology and the PAFCIC, headed by Professor Awad Aisha and Professor Habib Gamra for their invitation for this session. It's always very difficult, and it's an honor to speak between Horst Siever and Professor Siever and Professor Augusto Pichard, but I try to do my best. My topics today is the management of percutaneous intervention in high bleeding risk. As you know, coronary angioplasty in high bleeding risk patient remains very, very complicated because the fragile balance between bleeding and thrombosis. And this balance is very high when there is atrial fibrillation and ischemic disease that constitute dangerous combination. The best use of dual or triple antithrombotic therapy is one of my focus in this presentation, and the other is the guideline and the future perspective in this presentation. We begin by a clinical case. It's an 83-year-old woman who suffered chronic HTA with the history of external hemorrhoids. She had a paroxystic atrial fibrillation since 2010 and the new oral anticoagulant. She had on September 2019 palpitation increases that revealed NSTEMI troponin positive, and the echo revealed the left atrium slightly dilated with a good ejection fraction. The EKG revealed the sinus rhythm with the bifascicular block, and the patient was treated by clopidogrel, rivaroxaban, and aspirin. She had a radial coronarography with the 2 vessel lesion, and we did angioplasty with the 2 stent, the ONYX, on the LDA and the circ. This is the lesion of the LAD, proximal LAD. There is a lesion of the ostial circumflex. The right coronary was good. We do the angioplasty. You have the slide, please, Habib?
Yes, Samir, we see it very well.
Okay, we do the stent 2.526 ONYX on the LAD. We do another stent on the proximal circ. And the final result seems good. And this patient have a favorable improvement of the angioplasty, and the discharge treatment was rivaroxaban, clopidogrel, and aspirin. But 1 week after, she had moderate rectorrhea, and we did electrocoagulation and switched to apixaban, stopped aspirin, and used dual therapy, apixaban twice and clopidogrel for 6 months. there was a favorable evolution with neither ischemic nor hemorrhagic event. This case is very important to balance between the ischemic and the thrombosis, the ischemic and bleeding risk, and during and after PCA, management of patients with atrial fibrillation must balance the risk of bleeding with the risk of thrombosis. And the risk of bleeding is very important when we do a PCA and in a person who had atrial fibrillation, like you see. This slide is very important to explain the two phases of acute coronary syndrome risk, and it shows the thrombosis, the thrombotic risk is more important in the first months than bleeding risk, and the bleeding risk is very important after 1 month. That's why the recommendation try to recommend hard treatment in the first months, and after we try to delay some treatment. And for this, the European Society of Cardiology use a risk score for guidance the duration of dual antiplatelet therapy, and the two score is the score precise depth in the moment of the angioplasty, or the score depth after 1 year after angioplasty. This slide we can download from internet, this precise depth, and the items used was the hemoglobin, the calculation of the hemoglobin, the white blood counter, the age, the creatinine clearance, if there is a prior bleeding, and when the score is more than 25, we use short depth, and when the score is inferior to 25, we use standard or long depth. For the depth score, after 1 year after the angioplasty, there's another item like smoking, diabetes, and it's important to mention the paclitaxel eluting stent, because it's not good for bleeding, or the stent diameter that is inferior to 3 millimeters. There's another score that is the academic research consortium on HBR that we use easily, and summarize the high bleeding risk patient on this slide. And we see that the age over than 75, we see prior bleeding, we see creatinine clearance, we see any stroke before, any liver disease, any use of non-steroid or steroid before angioplasty. And this patient who undergo to PCI and high bleeding risk are about 30% of our patients. And the major bleeding after PCI is multiplied by 4 short or long-term mortality. And the management of this patient remains controversial, and it's important to choose the type of the stent, BMS or DES, or and the duration of the depth. How to reduce hemorrhagic complication? We must deal with the association of anticoagulant, duration of antiplatelet therapy, the type of stent, the use of PCI or cabbage, and the use of vascular access, radial, is more interesting, and we must prevent gastrointestinal bleeding. On the time of the study on the type of the stent, we can tell that the leaders-free study is the first randomized study to evaluate efficacy and security of short depth with polymer-free DES/BMS in 2004-66 high bleeding risk patient. And this study show and demonstrate superior clinical efficacy of DES versus BMS with 50% reduction with revascularization risk and superior security of DES with 29 MACEs reduction, including stent thrombosis. This is the graph that showed this leader study. There's another study with the Synergy and Rebel, compared Synergy and Rebel senior trial, and the MACE for 1 year, and the MACE was good for the Synergy, and the safety better for the Synergy slash Rebel BMS. The third study is ONYX-1 global study. It's the only DES versus DES trial in high bleeding risk patient with 1 month's depth, and it's compare Resolute ONYX with Biofreedom. And we see that device success is more interesting by Resolute than Biofreedom, and the safety and DES was safe and effective in HBR patient with 1 month's depth. The one clear US and Japan is the same study that the performance was very interesting, that ONYX study reinforced the safety and the security of this type of the stent. And now let's move to the recommendation and perspective in treatment on high bleeding risk patient. And we began by chronic coronary syndrome. And the recommendation of ESC in high bleeding patient was dual therapy for 1 month to 3 months, aspirin clopidogrel. The questions for the moment is, there is alternative. Can we safely withdraw aspirin when novel, more potent P2A12 inhibitor are used? And for discussion, multiple study like stop depth use 1 month's depth and compare group single antiplatelet and dual antiplatelet, and we see that the MACE is the same, and in bleeding is more important in 12 months than 1 month, 1 month single app. Ticagrelor do the same with this the Twilight trial that enrollment 3 months, and ticagrelor with aspirin for 15 months, and ticagrelor only. And we see that on the MACE it's the same, and in bleeding ticagrelor single is more efficient and more safety than ticagrelor aspirin. That's why the recommendation, European recommendation and American recommendation in high bleeding risk 1 month for BMS, 3 months for DES, and the European the same, 3 months for DES and 1 month for BMS, with the relevant of B and C recommendation. What's about acute coronary syndrome? The ESC 2020 highlight on bleeding risk on very high risk that 1 month dual therapy aspirin clopidogrel and clopidogrel for long term, and in high risk aspirin clopidogrel 3 months and aspirin only for the long term. What about the non-STEMI? The non-STEMI in high bleeding risk, aspirin ticagrelor or clopidogrel aspirin for 6 months. And now what about atrial fibrillation, PCI, and high bleeding risk? You know that 1 to 2 million persons can have revascularization and have atrial fibrillation and take oral anticoagulants. And there is a huge difference between person who have atrial fibrillation and no atrial fibrillation in the mortality when we want to do a PCI. The classical indication for anticoagulation was paroxystic, persistent, or permanent AF with such VASC score more than 2, mechanic prothetic valve, deep venous thrombosis, and pulmonary embolism. And this slide shows us the network of 4 antithrombotic treatment regimens, and the first regimen study was worst, and after Pioneer with rivaroxaban, Redule with dabigatran, Augustus with apixaban, and the last test was Entrust. The worst study demonstrated the dual therapy with vitamin K plus clopidogrel reduced bleeding risk versus triple therapy, addition of aspirin, without compromising efficacy like we see in this graph. The MACE was good and the bleeding was less. Pioneer AF-PCI reduced composite endpoint bleeding event with rivaroxaban-based regimen versus VKA triple therapy. Redule significantly lower rate with lower rates bleeding with dabigatran dual therapy versus warfarin triple therapy. We see that all the studies go on ahead on the efficacy of dual therapy and the safety of dual therapy. And that's why the recommendation of European Society of Cardiology was in a high bleeding risk dual therapy clopidogrel oral anticoagulant for 12 months. The North American expert consensus recommends dual therapy as the default strategy for most patients, and for high bleeding risk, triple therapy, oral anticoagulant, and DAPT for 1 week, and after double therapy, ONYX plus single antiplatelet for 6 months, and oral anticoagulant for 6 months. And the conclusion was that the development of new generation of DES, like ONYX, like Biofreedom, allows us to deal with high bleeding risk We must use always vascular access, and radial access is preferred. We must use gastrointestinal protection. Clopidogrel is more recommended in high bleed risk patient. And for the length, in chronic coronary syndrome, we do 1 to 3 months DAPT, then long-term single therapy. For the SCS in HBR, we do 1 to 3 months DAPT for non-STEMI and 6 months DAPT for STEMI, then long-term single therapy. And when we have atrial fibrillation and PCI in HBR, we use the new oral anticoagulation plus 1 antiplatelet for 6 months, then 1 new anticoagulant for long term. Thank you for your attention.